Assalamu alaikum. This is part 2 of the presentation Dry Mouth Xerostomia. This part 2 is on the management of xerostomia. The evidence-based recommendation in this lecture are based on high-quality studies of either level A or level B. That includes 2 systematic reviews and 11 randomized controlled trials and 2 prospective cohort studies. They covered the following items in the management of xerostomia: the parasympathomimetic drugs used as secretogogues, including pilocarpine and cevimeline; the disease-modifying agents, whether this is Sjogren's syndrome or radiation therapy, including Interferon-alpha and monoclonal antibodies, Rituximab; and the radioprotection, amifostine; and the procedure of submandibular gland transfer, the modifications on the diet that can bring about symptomatic relief, local stimulants to the mouth, including lubricants and protectants, saliva substitutes and artificial saliva, mouth rinses, mouthwashes, and toothpastes. And we'll also cover acupuncture and novel therapies, including gene therapy and electro-stimulation of the lingual nerve. The parasympathomimetics secretogogues would work better if there is an appreciable difference between the resting and the stimulated salivary flow rates. But even in patients with minimal salivary residual functions after radiotherapy or after Sjogren's syndrome or after extensive surgery, for example, they can still work by stimulation of the residual functioning salivary tissue. This would help in 2 things: the relief of the sense of dryness of the mouth and also providing enough saliva to have the protective effects in the oral cavity. 2 parasympathomimetic drugs are particularly of interest here: the pilocarpine and cevimeline. Both are approved by the US Food and Drug Administration for the treatment of xerostomia. Pilocarpine was used earlier for the treatment of xerostomia. It's a non-selective muscarinic agonist. Because it is non-selective, it has different actions on other parts of the body, whereas cevimeline has specific affinity for receptor subtypes not present in the cardiac or the pulmonary tissue. Pilocarpine, through its action on AMI3 muscarinic receptors, can stimulate the residual functioning salivary glands. In 2 randomized controlled trials, it showed significant increase in saliva output, as well as improved subjective sensation of xerostomia. The duration of the increased salivary flow would take about 2 to 3 hours from the oral intake of a pilocarpine tablet. It's usually given in the dose of 5 milligrams orally 3 times a day and can be titrated up to 10 milligrams 3 times daily. Classification of this recommendation is the highest possible, class 1 evidence, a level of evidence A. It would take about 2 months for the pilocarpine to give its maximum effect after starting the pilocarpine orally. But the real issue with pilocarpine is this: the side effects, because it's a non-specific muscarinic stimulant. It acts on several other systems in the body, and the side effects would include excessive sweating, rhinitis, urinary and gastrointestinal tract disturbances, and risk of having untoward cardiovascular and pulmonary effects as well. It's therefore contraindicated with gastric ulcer and uncontrolled asthma and hypertension, or in patients on beta-adrenergic blockers. Because of the numerous side effects, attempts were made to explore whether pilocarpine could be used locally in the mouth. A randomized controlled trial tested pilocarpine as a mouthwash formulation, 1% or 2%, used for 1 minute. It increased objectively the salivary flow, and this lasted for 75 minutes for both concentrations, the 1% and the 2% pilocarpine, and there were no significant side effects. The subject had also had these sensations of increased salivary flow, and this was particularly noticed with the 2% concentration. And obviously the use of pilocarpine locally would reduce the side effects. Can pilocarpine prevent the radiotherapy-induced hyposalivation before it is actually established, before the damage has been done? This was investigated by 7 randomized controlled trials in which the pilocarpine was given orally in the course of the radiotherapy treatment and up to 3 months after this. Out of the 7 randomized controlled trials, 4 of them showed no significant difference between patients receiving pilocarpine or patients on placebo, whereas in the others, the remaining 3, there was some significant improvement in both the subjective sensation of dryness of the mouth and the objective outcome of salivary flow in the treatment group versus the placebo. There remains, however, little robust evidence to suggest efficacy of pilocarpine in the prevention of xerostomia and hyposalivation. It can still be used in the treatment after the radiotherapy with some effects, but there is little evidence to show that it can actually prevent the radiotherapy-induced hyposalivation. When pilocarpine is used in the management of the established radiotherapy-induced hyposalivation, in 6 randomized controlled trials, the efficacy of the pilocarpine in the treatment of the dryness of the mouth, the majority of these 6 reported that pilocarpine taken 3 times a day, either in the dose of 5 milligrams or 10 milligrams, is effective in lessening the sensation of the oral cavity dryness and also in increasing objectively the salivary flow rate in patients who had radiotherapy. There will be some adverse side effects, and these can be frequent and dose dependently would increase with the higher doses of the pilocarpine and can sometimes be problematic. The other parasympathomimetic is Cevimeline hydrochloride, which is a derivative of acetylcholine. It is an acetylcholine analog. It works selectively on AMI3 receptors, muscarinic AMI3 receptors in the lacrimal and salivary glands, and other exocrine glands such as the sweat glands, the pancreas, and the intestinal glands. But it can also increase the muscle tone and motility in the GI and the urinary tracts, but have very little effect on the cardiac and the pulmonary receptors. It has been approved by the FDA for the relief of the xerostomia in patients with Sjogren's syndrome. And in at least 2 randomized controlled trials, Cevimeline hydrochloride was tried on primary and secondary Sjogren's syndrome patients, and in both randomized controlled trials, the oral Cevimeline improved the xerostomia, subjective sensation, and the hyposalivation objectively. It's recommended to give Cevimeline at 30 milligrams 3 times a day orally for both the primary and the secondary Sjogren's syndrome patients, and this recommendation has taken the highest class 1 recommendation level of evidence is A. In addition to its established role in the management of Sjogren's syndrome, primary or secondary, Cevimeline was also tried in the management of radiotherapy-induced hyposalivation, and it showed a significantly greater increase in the unstimulated salivary, in the resting, the basic salivary flow rate, but not the stimulated compared to a placebo. It also helped with the subjective sensation of the dryness of the mouth. So it is actually, there is some evidence that it can also be of help in the group of patients who have hyposalivation because of radiotherapy. Several other medications and drugs were used to control the systemic disease that cause the hyposalivation and the xerostomia, the most common of which is the Sjogren's syndrome. These include the Interferon-alpha in a lozenge form. This was shown to enhance the salivary flow rate in the primary Sjogren's syndrome patients. The anti-tumor necrosis factor agents, monoclonal antibodies such as Rituximab, was not recommended because it couldn't show any effect. Steroids had also been tried earlier, but again showed no objective effects on salivary flow rates. The non-virilizing dihydroepiandrosterone was also tried in the primary Sjogren's syndrome with no much effect. There wasn't much evidence to support the use of local oral cavity stimulants or lubricants and protectants for hyposalivation and xerostomia, except perhaps for the use of chewing gum. Chewing gum can stimulate the reflex secreting of saliva by the act of chewing itself. So that's the only one of this group of local stimulants and lubricants that has some evidence to support. But of course, patients would find some of these products useful in alleviating the sense of dryness of the mouth, even without objective increase in the salivary flow rate, and professional judgment and the patient preference would support a use of a specific product that the patient would find useful. Another monoclonal antibody, the Rituximab, which is a monoclonal antibody that reacts with the CD20 antigen present on about 90% of the beta cells lymphocytes. A patient with primary Sjögren's syndrome were treated with this infusion of Rituximab weekly, and they showed a very good response. And there was a subjective improvement in their symptoms, and the salivary gland functioning also improved, and the peripheral beta cells count has decreased. And if labial salivary gland biopsies were taken, it could be shown that the lymphocyte infiltration, particularly by the CD20 positive beta cells, had decreased, and the effect of the monoclonal antibody was sustained for 10 months. We still don't have any good way of reversing any radiotherapy-induced damage to the salivary gland tissues once this is established. And the way forward is to try and prevent this damage during the radiotherapy course. And the intensity modulated radiotherapy was shown to reduce the frequency and the severity of the dryness of the mouth induced by the radiotherapy. And also the radioprotectant amifostine had a similar effect. It can also prevent or decrease the frequency and the severity of the xerostomia. A meta-analysis showed 4 different randomized controlled trials that all agreed that amifostine is effective in reducing the risk of developing either grade 2 or grade 3 xerostomia by 76 and 67% respectively. This is significant. The amifostine is used intravenously but can cause adverse side effects, including hypotension in about 2/3 of the patients, and also nausea. So the subcutaneous route was investigated, and it seems that the incidence of hypotension and nausea is less with the subcutaneous route for the amifostine. There is no evidence to suggest that amifostine reduced the efficacy of the anti-cancer therapy, the radiotherapy or the chemotherapy. As all the randomized controlled trials in these meta-analyses were actually on patients who had received conventional radiotherapy, it's not yet clear if the effect of the radioprotectant amifostine in the cases of patients who are being treated by intensity modulated radiotherapy can still be noticed or not. This will be clear in further studies. A third way of preventing radiotherapy-induced hyposalivation is submandibular gland transfer. The gland itself would be relocated from the submandibular triangle to the submental triangle, away from the portal of the radiotherapy field. A phase 2 study suggested that this is effective. Patients who were treated by radiotherapy following such a submandibular gland transfer, 81% of these patients had no or minimal xerostomia at the end of the radiotherapy treatment. And similar results were obtained from other trials, including a trial comparing the effect of the submandibular gland transfer compared with the use of pilocarpine during the radiotherapy, and it was shown that submandibular gland transfer is actually more effective. But of course, such an invasive procedure is not without risks. The surgical complications including facial edema and submental swelling, shoulder weakness, and neck numbness. The long-term efficacy of this approach has been demonstrated, and it was shown to be very adequate. It remains an invasive procedure that can only be applied to patients whose cancers would require surgical resection before the radiotherapy. And finally, acupuncture. There are some available studies that suggested that acupuncture could provide symptomatic relief from the sense of dryness, including randomized crossover studies. But 3 and independent large systematic reviews concluded that there remains insufficient evidence to support that acupuncture can be used as a standard treatment for dryness of the mouth. Even when it is suggested that acupuncture is of some help in symptomatic relief, there was no evidence or significant changes in the stimulated or the unstimulated salivary production. And then gene therapy in the management of xerostomia and hyposalivation. And a phase 1 study was conducted to test the effect of transferring a gene, Aquaporin 1, mediated on an adenovirus DNA, and this was transferred to the parotid gland through retroductal cannulation. One of the 2 parotids had this procedure, the cannulation and the gene implantation, and it was demonstrated objectively that there was positive response to the gene therapy, and that 6 of the 11 patients had enhanced parotid flow rates and reduction in the subjective sensation of the dry mouth. Measures to adjust the diet to help in relieving the sense of dryness of the mouth start with frequent and regular sipping of water. Drinking water not only relieves the dryness of the mouth, but also eases in swallowing and hydrate the tissues in the mouth and clean the oral cavity. If dry food is to be taken, it should be accompanied by frequent sips of water. In general, avoidance of dry or hard or sticky or acidic food would be helpful, particularly food of extreme of temperatures, too cold or too hot, and sugary foods that may increase the risk of dental caries in patients with hyposalivation. It's best to try and cut down or avoid caffeine or alcoholic beverages because they would dehydrate the oral cavity tissues and cause general dehydration and increase the sense of oral dryness. A diet that contains food rich in moisture would also be helpful. Vitamin C tablets as a reducing agent break down the disulfide bonds between the cysteine residues in the proteins, and this leads to a decrease in the viscosity of the saliva. But frequent use of vitamin C is not recommended because citric acid and sweeteners are often added to the vitamin C tablets to reduce the bitter taste. The citric acid and the sweeteners could have erosive effects on the dental enamel. Smoking should also be avoided as much as possible, as it can further irritate the dry oral cavity and also cause further dryness of the mucosa. Next is oral lubricants and protectants, starting with olive oil, which is one of the simplest and cheapest oral lubricants and has an established benefit in the treatment of dry mouth. Also, commercially available oral lubricants can be of help. These are predominantly based on carboxymethyl cellulose gel to give the solution some viscosity. They also incorporate other substances like antimicrobial agents, lactoferrin or lysozymes or lactopyroxidase. These are naturally found in saliva and can be added to the carboxymethyl cellulose to give some antimicrobial effect. Oral lubricants and antimicrobial salivary substitutes can be applied as a bolus or as a slowly released intraoral device in the mouth. The use of a humidifier, particularly at a bedside during sleep, can help in alleviating the symptom of dry mouth and also dry nasal passages. Significant improvement in the symptoms can be achieved by shifting the medications taken by an individual patient to a similar drug with fewer xerostomic side effects. For example, the serotonin reuptake inhibitors cause much less dry mouth than tricyclic antidepressants. Also, changing the timing and the dosing schedule of the medications can help. Avoiding taking the medications at night before bedtime can help because this is the time where the salivary flow is at its lowest level. Patients should be encouraged to lubricate their mouth with water prior to the ingestion of the pills, and followed after intake of the pills by a full glass of water. Dividing the drug dosages to smaller portions across the day may also help, and informing patients which medications can and cannot be crushed for ingestion is helpful. And saliva substitutes or artificial saliva. Using oral mouthwashes, gels or rinses or sprays or artificial saliva can all help to reduce the discomfort and improve the function of the oral cavity momentarily. These oral care products are specifically formulated for the dry mouth. They contain no detergents, they have a mild taste, they contain antimicrobial routine. They also contain a thickening agent to provide some viscosity, plus their protective properties. So they have different composition and different viscosity. Among these agents is of prime importance the carboxymethylcellulose, a mucopolysaccharide, but other agents can also be used, including glycerol polymer, gel base, or natural mucines, hydroxyethylcellulose, xanthan gum, glycerol, linseed, polyethylene oxide, plus the addition of some salts, preservatives, and sweeteners. These products, either mouth rinses or mouthwashes or toothpaste, can all have a short-term relief from the sense of dryness in the mouth, up to 4 hours or so, and can also help in keeping the patient's mouth and teeth and gums healthy. They can improve the pH buffering in the oral cavity, and if you incorporate synthetic detergents like sodium lauryl sulfate or osmoprotectants like glycine betaine, it also improves the oral cavity functions, but again only for short periods, few hours, maximum 4 hours at a time. Another important category in the home remedies for dry mouth is preventive dental care, because extra measures should be taken to prevent the oral complications from low salivary output, including frequent dental and oral evaluation. Between 4 and 6 months, you would need to have a check with the dentist, and radiographs of the teeth should be performed annually. And to prevent dental caries, meticulous oral hygiene and a low sugar diet and regular use of topical fluorides are recommended. In fact, the daily use of a neutral pH sodium fluoride is the most effective means of preventing rampant hyposalivation-induced caries, dental caries. And if the patient is using any dentures, it's important to prevent fungal colonization by daily immersion of the dentures for 30 minutes in chlorhexidine solution, either 0.12% solution or 1% sodium hypochlorite solution. Also, it's important to have the dentures adjusted to avoid any friction or injury to the oral mucosa, and use dental adhesives because the dryness of the mouth may prevent proper alignment of the dentures, and to consider the use of implant bone prosthesis, which may have lower side effects. But if oral candidiasis develops, which is a common complication for patients with salivary gland hypofunction, it needs to be treated promptly. Chlorhexidine 0.12% solution used twice daily, 10 milliliters, to rinse the oral cavity, swish and spit at least twice daily. Or if angular cheilitis has developed, the use of ointments containing either nystatin or triamcinolone can be applied topically 4 times daily, or the use of clotrimazole approaches 10 milligrams, again 4 or 5 times daily for at least 10 days. Systemic therapy with antifungal agents should be reserved for patients who are immunocompromised or cases that are refractory to topical therapy. Another line of management would be to try and increase the salivary output, particularly from the major salivary glands, in patients who are still having residual functioning salivary gland tissue. And various products, including the chewing gums and hard candies, lozenges, and sprays, have all been tried. They must be sugar-free and non-acidic, of course, to avoid any dental erosion. Chewing gums in particular is of some help in producing some salivary output through the reflex action mediated by the periodontal receptors by chewing. And of course, additives can be added to the chewing gums or the other products to help in preventing dental caries, like sugar-free xylitol containing and mints and candies and the gums. Chewing gums will stimulate salivary flow, but not much, and can provide some transient relief of xerostomia. Although it is effective in stimulating saliva, the usefulness of chewing gum in the management of xerostomia is limited. It is, however, more effective in reducing the dryness of the mouth than all the mouth lubricants, particularly in patients who had radiotherapy or hemodialysis. A novel way of trying to increase the salivary flow is electrostimulation of the salivary glands via the lingual nerves. This can reduce the symptoms of dry mouth and increase the salivary flow. The electrostimulation would augment the salivary reflex by directly stimulating the efferent neural pathways of the submandibular and the sublingual salivary glands. They are the glands more important in providing the basal salivary output. Stimulating electrodes can be incorporated in a removable device or a dental implant to directly stimulate the lingual nerves. Literature on the effectiveness is fairly limited, but there is a large randomized controlled trial on the way on patients with xerostomia after head and neck cancers and radiotherapy-induced hyposalivation. By this, we come to the end of this presentation on the management of xerostomia and salivary hypofunction. Assalamu alaikum.